ask sort of one final question about frontline regimens. We haven't seen the results of 8x8, right, which is ipi-nivo versus nivo. So maybe a two-sided question. Is there anybody that you use immune monotherapy in, and do you really believe ipi's adding anything?
Oh, well, that's interesting. I don't give PD-1 monotherapy. I heard David does, so I'd be curious to hear about that. To be honest, I do think trials are important. We'd be remiss in frontline setting not to talk about PDIGREE and PROBE, and so there are cooperative group trials still ongoing now, where adaptive design, kind of like Hans's approach, ipi-nivo first, then followed by an early addition of cabo-nivo for PDIGREE. PROBE is the question of consolidated nephrectomy 3 months into immunotherapy. So I think that there's still reasonable options. If I use CTLA-4 blockade, to your initial question, I try to use it early. We've seen from multiple trials that using salvage ipilimumab is not effective. But I'd be curious to hear about PD-1 monotherapy.
So you asked two questions. I'm going to wait to answer Tian's question, which I don't know. They're sort of separate, I think.
Yeah, they're separate. Do you use PD-1 do you use immune monotherapy in any patients?
Yes. I have a discussion with them about risk, and as Hans was just saying, it's double the risk of severe toxicity, and if they go like this, then we give them PD-1, alone. So there's a percentage of patients, they tend to be older, tend to be sicker, less motivated. The data with single-agent PD-1, admittedly at very selected centers, is pretty good.
Yeah.
Both in 427, Keynote 427, and the HCRN trial has ridiculously good data, so there's that.
Right.
It's obviously not phase 3 data.
Yeah.
So, and it's certainly more tolerable. Now, whether 8x8 is going to be positive or not is a totally different question. We've been waiting, it seems like a decade, for that trial to read out. I mean, to me, let's see, it may not. The trial is underpowered, it's small, it may not have the right endpoint. We'll see. That will be practice changing or not in the US or Europe? It's possible, but either way, to me, it's about building on IO backbones. So even if we use less CTLA-4 in the future, I'm hoping to build on PD-1 plus the next exciting, targeted immune therapy. So that's why I'm hoping for, and hoping those are the controls. To me, the best controls for future studies are ones that have IO in the control arm.
Yeah, I agree. Hans, last word on this.
Yeah, so totally agree with David that 8x8. I don't think it's going to be a defining study to tell us where ipilimumab stands. I think we need to look at the aggregate of data, right? It's an underpowered trial, and I think that we all know that ipilimumab has single-agent activity, right? 10–15%, right? And that's what you see across all these different trials. It started, for example, with PD-1 and then did some salvage with PD-1. CTLA-4. I think the trial to watch, quite frankly, is the control arm on COSMIC-313. I think that's the biggest contribution to the field from that study. I don't think the triplet should be approved, but I think the control arm will actually show modern-day use of PD-1 CTLA-4, and the curves look pretty good. So we have to see what the long-term follow-up is. I think there's going to be real value to the community.
Yeah. And there may be some better follow-up and less censoring on that trial.
Better follow-up, less censoring, more modern use of TKIs, switching over to TKIs if needed be. So I think that's going to be actually a really good data set.